Okay, so it's 12:01, so we will get started. Thanks for joining us today in another one of our COVID-19 and diabetes webinars in our Diabetes Canada webinar series. We're really glad that you could join us today for a presentation called Enhanced Sick Day Self-Management, Keeping Clients Safe During the COVID-19 Pandemic. Presented by Susie Jin and Catherine Yu. So we're really excited, and what we typically do first is we'll do some polling questions just to get a sense of who our audience is today. So our first question is, what is your profession? So if you could go ahead and participate in the poll, we'll give it about 30 seconds and then we'll see who's joining us today. Okay, great. So 50% of our audience today are registered nurses. We have a couple of nurse practitioners, about 20% registered dietitian, some pharmacists. We have a family physician or a general practitioner, and about 14% are other. So a good diverse group of folks joining us today. And we will do our second polling question, which we just would like to know where you're viewing from today. So which province do you live in? Okay, so as has been the case in our series, the majority of folks are calling in from Ontario, probably because we're watching at lunchtime, noon Eastern time, but really nice to see we have someone from every province joining us today. So 8% British Columbia, 16% Alberta. Yeah, so thank you so much. So without further ado, I'll pass it over to Catherine and Susie for today's presentation.
Thanks, Grace, and thank you to Joanne, Alice, and other members of Diabetes Canada for inviting Susie and I to present on a topic that's near and dear to our hearts, particularly Susie's. So my name is Catherine Yu. I'm an endocrinologist at St. Michael's Hospital, and I'm pleased to present with Susie Jin, who is a pharmacist extraordinaire, a close friend and colleague who is very passionate about diabetes care and would never leave us for asthma, as we discussed yesterday. By the end of this webinar, you should be able to counsel adults clients effectively on sick day management, describe a stepwise approach for individualizing ambulatory management of severe hyperglycemia, and list 3 reasons for which adult clients must go to the hospital. This session will be interactive, so we're going to keep about 15 to 20 minutes at the end to answer any questions that you might have. So if you have a question, feel free to jot it down and we'll get to those at the end, just for smoothness of presentation, because I'm not quite a Zoom expert yet. In order to go through these objectives, we'll walk through some perspectives. So just to step back and think about COVID and diabetes. We'll talk about sort of standard sick day management, step up to really sick day management, and then finish with really, really sick day management. So starting with some perspective, this article recently came up last month, looking at the rates of hospital admissions and hospital occupancy during the COVID pandemic. And so many of you, I'm sure, are also aware of this. So in many Canadian hospitals, admissions are down 25 to 50%, and our ward beds have been empty. We know that not all 25% to 50% of these admissions are unnecessary. And so the corollary is that people who need to come into hospital aren't coming in because they're afraid, And when they do present, they present with worse disease that can be reversible. And so, in fact, while the push has always been, let's get patients out of hospital, it's a mixed blessing. And I think this cartoon depicts this really nicely. I'll give you a moment to read that, about how a good thing, too much of a good thing, can actually be quite bad. And to give you a bit of perspective, so I think what we need is balance. Just as we're finding balance in our new lives during this pandemic, we need to help our patients find a balance between appropriate stay-at-home management and appropriate acute care assessments. And then I'm happy to share some stories.
Yeah, so it's my turn to be able to say some awesome words on behalf of everybody on the webinar so far. So I see that we have about 99, almost 100 participants. And I really wanted to take this opportunity to, unfortunately you guys are muted and I know you'd say it better than me, but to thank Catherine for being our hero. And I know that we always say, people on the front line are heroes, but I think that almost diminishes what Catherine actually means to all of us. As you know, she is the one who really led us all to bringing the guidelines to life. She has changed positively the care of people with diabetes, not only across our nation, but internationally as well. So I know if you guys could, you'd all be like with your Zooms clapping and all that stuff. But I just, Catherine, I wanted to thank you from the bottom of our hearts. And speaking of hearts, when Catherine and I thought about putting this together, there's always those theories and there's the concepts that we want to try to get across with respect to prevention, helping people know how to stay safe or manage their sick day, or prevent and then manage and so forth. But what I think we didn't realize is that Catherine actually was redeployed, and in her role as endocrinologist, she actually had to be on the front lines of the COVID unit and actually accepting people into the hospital that she worked at, St. Mike's, and servicing those people with COVID. So I thought, wow, not only is she a hero in what she's done for diabetes care, but even more so now. So we thought, by way of keeping it personal, we thought it'd be pretty interesting to find out what did she see, some of the interesting stories that she saw, and then finding out if there's a way that we could have helped keep them at home safe and responsibly before it actually got to the really, really sick.
Thanks, Susie. I had skipped over the introductions and said I would just introduce myself, and Susie didn't say anything, so I thought I'd gotten away with it. But knowing Susie, I should have known that I would not have gotten away with that. And it's also, while I, cut people off in person, I feel like it's ruder to cut off on Zoom. So anyways, so I'm pleased to share. So as Susie mentioned, I was attending on the COVID ward as part of redeployment at my hospital. And she pushed me to think of a couple of cases that would be relevant, and it actually was very hard. So I'm going to go through two cases with a COVID twist. And the first is just another gastro, and the second one is just another diabetic foot infection. So the first case is a 58-year-old man, Mr. O. His past medical history is significant for type 2 diabetes, ischemic heart disease, for which he had a recent CABG and then stent, nephrolithiasis, and BPH. And he presented with a history of nausea, vomiting, profuse diarrhea, and a maculopapular rash. So a very viral looking pruritic exanthem. So he, sounds typical, bad timing. But the kicker is that 4 days later, he then presented to the emergency department via EMS with syncope, and given his relatively recent bad heart history, he was treated as a code STEMI. When he was resuscitated, he was found to have a creatinine of 587 from his baseline of 100 to 120. He ended up not being code STEMI. What it was that he probably had a viral gastro, as evidenced by his symptomatology, the viral exanthem, resulting in severe ECFI depletion, resulting in AKI, as well as his syncope. And because of his fever and rash, he was treated as a COVID PUI, but he ended up being COVID negative with his creatinine going back down to his baseline of 127. So when I was telling Susie this story, I told her, I said, I have something embarrassing. So Mr. O is actually one of my outpatients who I see for diabetes. And I thought, wow, you know, I've gone through sick day management. I've gone through SADMANs. I've given him the handout, and yet this still happened. Mind you, his blood glucose was pristine before his admission and during his admission, but, you know, he did not go to emerge. The sort of, I think, the fear of coming into hospital had superseded sort of what he knew he was supposed to do. And I think we need to recognize that and really take the opportunity to stress that in each of our encounters with patients. So now when I have telephone appointments with my patients, I say, if you need to come to hospital, it's okay, we have precautions, just as further reassurance to know that we're still there for them. So that was the first case. The second case was a 72-year-old man, not my patient, but now he is, who had a past medical history of type 2 diabetes and Klinefelter syndrome, and was basically was followed by primary care, kind of lost to care. He presented with a 2-week history of increasing redness of his right foot and shin, and an ulcer on the tip of his big toe. He was, he's somewhat underhoused, so he was febrile and brought in as a COVID PUI. An x-ray of his big toe showed osteomyelitis, and blood cultures on day 1 were positive for gram-positive cocci in chains. So the twist here, the backstory, is that 4 weeks ago, he was prescribed pressure stockings for venous stasis. However, CCAC was held, so he was self-applying them himself and maybe not taking them off appropriately. And he had no RN assessments. And I think because of reduced care, reduced monitoring, it was able to get to this point of osteomyelitis and a later assessment for care, which actually wasn't driven by his ulcer, but rather by his fever and concern for being a COVID PUI. But as with the other case, there's a happy ending. He defervesced and is being maintained on a 6-week course of oral antibiotics with close follow-up with infectious diseases, as well as myself, both for the type 2 diabetes and Klinefelter. So the other positive thing is he's just linked back with care, which he hadn't received for either of those in the last 50 years. I'm going to flip back to Susie now, who's going to, again, step back and just give us some thoughts about diabetes and COVID-19 preparedness.
Thanks, Catherine. So Catherine has shared some of her stories that she's seen when she's caring for people with COVID. I am a community pharmacist, and so I will see the opposite, well, the other extreme, right? The more prevention, or the early, what can we do when they're still at home? And I'll share, so one of my stories I had is early in the times of COVID, we did have people coming in. Of course, there was a lot of fear, a lot of unknowns, and I had people coming in and asking, should they take vitamin C to help prevent against COVID? And, you know, obviously you could try to answer those kinds of questions on the spot, but I think the other more important thing that we could actually do is take a minute to go back to, we really don't know what vitamin C does for COVID at that time, and possibly, recognize that they're in a really good, more preparedness state of change, more actionable state of change, and try to go over the evidence-based things that we can do to help prepare our bodies to fight off COVID if we were to come down, unfortunately, with COVID. So having said that, that's my way of telling Catherine, because I'm on video, so she'll know. The first thing I would do would be to really, I think at the forefront has always got to be, for my opinion, is mental health. As we all know, when we have a decreased capacity or are affected by mental health, that does affect our self-care capacity often, and as well as having other sequelae. And so Dr. Michael Vallis had done an excellent presentation on mental health, which is also available on the same Diabetes Canada Timed Right webinar series. So if you haven't had a chance to look at that, I will refer you to that, just as a nice lead into how we can help and support people with mental health during the times of COVID. Okay, the other thing is also very much at the forefront. If we're starting to think that they might be in a more stage of change, or a further actionable state of change, would be to possibly have another conversation or reopen the conversation about smoking cessation, smoking of any sort, if that's on board for that person. So again, just bring that into light. And then the vaccinations story. And I feel like with the hopefully the coming of a COVID vaccination, that is another idea of just putting it out there as an idea of, hey, when it comes out, make sure you get it. Unfortunately, sometimes I still will hear people, not the same people that unfortunately also don't want to get flu shots, will also be talking about, yeah, I don't know if I'm going to get that COVID vaccine when it comes out. So I think that every opportunity we have to remind them of the fear that they actually had about coming down with COVID would be another opportunity just to speak to the value of getting that vaccination when it does come out. Then with respect to the flu shot, simple questions I would say to them if they were asking me about something possibly that doesn't have as much evidence, I would actually be asking them if they did happen to get the flu shot, or if they do get their annual flu shot. So not just the one, but their annual flu shot. I think that now is what May. Sorry, we'll go back, but now is what May. So I think that obviously it's sort of how beneficial are you going to be by having it now? I think that's not so much, we're definitely going to be talking about it for make sure you get it next year. But there is one time when I will actually encourage it if I have had somebody, because now don't forget they're in that stage of change, and hopefully they're in a positive state of change. If they're that one person who I often have where they've had the flu shot before and they had such a bad experience, they were sick, and they'll never have a flu shot ever again in their life. It was the most worst experience ever. I'll always try to remind them that the flu shot does take 2 weeks to work. So of course, if they got sick shortly after getting the flu shot, it was really probably because they didn't get it early enough. But I'll also try to explain to them that, we have to get over that fear, because many times they might be at the stage where they're young and healthy, and maybe they're doing it, the flu shot, the more benefit they're getting is for the herd immunity, and they're actually doing it to possibly, hopefully protect the rest of our community from coming down with influenza. But later on in life, if they live with this fear of the flu shot, they will get to the point, possibly, if they're so lucky to live very long, where they might have complications and comorbid conditions where they personally would benefit from the flu shot. And so getting over that flu shot fear by just having one, just for the sake of having one, there would, I think, still be benefit. Okay, so with respect to pneumonia vaccinations, there are 2 vaccinations on the market. And so the questions I would ask or pose to them are, have they had both pneumonia vaccinations? And if not, then refer them, well, certainly if you know which ones they should be, then, go on ahead and have that conversation. And if not, refer them to somebody who actually does give the pneumococcal vaccination. So whether it be their primary care provider, I think most provinces across Canada, community pharmacists can give the pneumococcal vaccination, but having them speak to somebody about whether it's appropriate for them, whether they can have access to it, because in some provinces, depending on which one, it's not covered on the government plan, and is the timing right for them? So again, depending on comorbid conditions and which vaccinations they may already have on board, the timing might be, yes, they should get it now, or no, they should wait 8 weeks or a year, depending, to go ahead and get that shot. So just making sure that they're aware of it and that they need to double check what timing is best for them. And then with respect to the shingles vaccination, there are 2 shingles vaccinations on the market. But unlike the pneumonia vaccinations, where both are recommended in people with diabetes, I have to specify because that's different from the general population. But with respect to the shingles shot, there are 2 available. And in the shingles vaccination, quite honestly, it would be recommended pretty much for everybody over the age of 50. But the difference is that there is an older generation Zostavax 2 vaccination shingles shot, and then there's the newer generation Shingrix. And unlike the pneumonia vaccinations, where both are indicated, in the shingles vaccinations, if you've had the older vaccination, then the newer generation vaccination should be considered. But if you have not had the older generation, then don't worry about it, because we would just go with the newer Shingrix vaccination. The Shingrix vaccination is a 2-shot series. So the question would be, have you had your shingles shot? Which one? And if it was the Shingrix, did you get both shots, which would be 0 and then 2 or 6 months later. Okay, and then we get to the majority, the main crux of what our presentation today is on, which is to become glycemia-specific preparedness, which is awesome that Catherine's first person, awesome sugars, but which of course I would expect. So when we have glycemia-specific preparedness, we have the possibility of hypoglycemia and hyperglycemia. So the hypoglycemia is actually going to be covered in part 2 of this webinar series, which is next week, the same time, which will be hosted, or the guest speaker would be our other awesome hero, Dr. Alice Cheng. So stay tuned for that next week. And today's presentation is really going to concentrate on the hyperglycemia that we get in sick day. Okay, so speaking about the hyperglycemia, the first part we're going to talk about with respect to sick day management is possibly the prevention of how do we prevent that hyperglycemia from happening. And then we'll get into really sick day when how do we manage that hyperglycemia in sick day. And then of course, we're going to get into the really, really sick day. Okay, so speaking of sick day then, when it comes to the priorities of care, I think we can't just treat everybody the same, right? That person sitting in front of us, we want to individualize the care to them. And so a lot of that involves thinking about what can happen in sick day and what are they specifically at risk for. So, well, the first thing we can think about is hyperglycemia. We've already identified that there is hyperglycemia, but actually we haven't actually said why, right? Why is hyperglycemia naturally part of sick day? So just as a review, just a reminder for everybody, when we are sick, we have the counter-regulatory stress hormone release, right? So what I'm doing is I'm kind of trying to show that normally, in the perfect world, we live in a balance of insulin and counter-regulatory hormone are quite honestly moving together, being released and together, right? And when we're sick, unfortunately, we will have a rise in the counter-regulatory hormone release. So that would be the cortisol, the glucagon, the adrenaline, growth hormone, right? So all of those are going to increase, and those are going to cause the hyperglycemia. So of course, later on, we're going to talk about it, but if we don't increase our insulin accordingly, even if we make no changes, but we are sick and we're just still giving our same normal dose, we will have that hyperglycemic reaction. Okay, what else are we concerned about? Well, if we have fever, which Catherine's patient had, right? If we have fever, if we have vomiting and diarrhea, we are at risk of dehydration. And what is our real concern with that? Well, certainly, yes, there's the dehydration and the electrolyte abnormalities that are possible, which have other heart problems. But specifically, what the other thing we're really concerned about is the acute kidney injury that is exacerbated in the sick day state or sick state plus exacerbated with the dehydration, that if we can't manage it, we are at increased risk of acute kidney injury. Okay, and then what's the other thing we are concerned about is possibly diabetic ketoacidosis, right? And I think I explained that a little bit. Why do we get diabetic ketoacidosis? Diabetic ketoacidosis is that gap, and the bigger the gap is between the counter-regulatory hormones and endogenous or existing insulin, so I should say endogenous, existing insulin on board, the larger that gap, the higher the risk of diabetic ketoacidosis. So if we can bring that up, we're reducing our risk of DKA. Okay, so who is at risk for hyperglycemia? And yes, it's all people with diabetes. Sorry, let's be clear. All people with diabetes are at risk of hyperglycemia. How is the best way to prepare or mitigate the risk of hyperglycemia? Is to have them check their glucose, right? And I wrote increase in brackets because some people possibly, especially people type 1, are maybe already checking quite a bit. So whether you're increasing or not, certainly glucose monitoring. But let's just take a look at that statement just as it is. Does that mean if I want to prepare everybody, all my patients with diabetes for sick day, everybody I should be giving them a blood glucose meter? And truthfully, you and I both know we have people who are on metformin alone, metformin and a DPP-4, for example, they're not checking their sugars, and that's responsible enough, because if they are maintaining good A1C, do they need to have a blood glucose meter at home? Do they need to be checking, right? We also have people who are on insulin, basal insulin, let's say, and a sulfonylurea, and they're also not checking. Should they be checking? And I think we would all love that if they had access to it, yes. But truthfully, I think when we go back to just thinking about who should be checking their sugars, who would benefit from blood glucose monitoring, I think that we have to look at the 3 criteria. They have to meet all 3 criteria. First criteria is that either the person themselves or a caregiver can demonstrate proficiency with actually using the meter, because if not, it's a waste of actually giving them, and sometimes it's just stressing them out with asking them what their sugars are. The other thing is either the patient or their caregiver has to recognize, has to be able to know what their targets are. So I actually say not just knowing your targets, but interpreting the values, right? They have to know what their targets are, and they have to know when they're outside of the targets. And then the third thing is they have to be willing and motivated to take action on the results, right? Because checking your sugars without taking the action on the results is actually still quite useless, right? So an action could easily be picking up the phone and phoning their healthcare provider when they are in a sick day and saying, you know, what should I do? But at least they are actioning on those results. So having said that, when I'm thinking about who should be checking their sugars, I want to make sure that everybody I place a blood glucose meter in their hands, that they meet those 3 criteria. They know how to action on the results. They know how to use the meter. Okay, so with respect to the dehydration, who is at risk of dehydration? Technically, Catherine, all people, right? All people are at risk. And so that's actually interesting. That's actually expanding this out. So a lot of people on this call, many of us care for specifically people with diabetes, and others of us are actually caring for just everybody. So how can I help prepare everybody for possibly sick day or COVID, or how can I prevent acute kidney injury in everybody? We could make sure that they have oral rehydration solutions home. And although, because that does cost some money, so access could be an issue, at least have raw soups in their house available at all times, possibly. So that's just another thing. Having said that, if they're able to rehydrate appropriately, are they at risk of dehydration? Technically, we've managed their dehydration by appropriately rehydrating. And when I say appropriately, a lot of times I'll tell people, oh, you should have oral rehydration solutions, but they don't, they might vomit 2 to 3 cups of fluid, but they're only taking 1 cup of oral rehydration solution. So it has to be, volume out comes volume back in. But once you've been able to mitigate the risk of dehydration, then technically we've actually reduced that risk, right? So when we read who is at risk of dehydration and acute kidney injury, it's those who are at risk with fever, vomiting, and diarrhea. and who are unable to replace the appropriate fluids. And it's in those people that we hold SADMAN's medications. So I know that's a little bit of nuances, because why am I careful not to just jump and hold SADMAN's meds? Is because, for example, if I hold a sulfonylurea too early, possibly, we're just contributing to the hyperglycemia. On the other hand, the other last S is an SGLT2, so I might actually consider holding that earlier than the sulfonylurea. Those are just, I guess, you know, we all, the SADMANS is an excellent algorithm, but how we interpret it, how we actually manage it can sometimes help people and without holding too early, but not holding too late. Okay, so with respect to diabetic ketoacidosis, who is at risk? So basically, remember, it's those people who have that bigger gap. So we have this hyperglycemic effect happening due to the counter-regulatory hormones. It's pretty much the people who are at risk are the ones who actually have less endogenous insulin, because technically, remember I was saying how everything's in balance, and if we were without diabetes, then we would be able to, with the hormone release, the counter-regulatory hormone release goes up, but so does our natural endogenous release. So the people who are at higher risk of DKA are there's those literally that have a compromised endogenous release of insulin release. So that would be type 1 diabetes, type 2 who have progressed, their diabetes has progressed to the point where they actually need basal bolus insulin, implies that they have less endogenous insulin available. And then anybody who's on an SGLT2, right? So I know you can use it off label in type 1. So literally anybody, even if you're just, you know, metformin and an SGLT2, are you at risk of DKA? Because the SGLT2, which is causing, hopefully, lowering the sugar levels, will have less of the insulin being released, possibly. And how do we mitigate for the DKA? Would be to make sure they're doing all the first two buckets and checking ketones. And you'll see the ketones, I also have that red little star there too, because a ketone meter, just like a blood glucose meter, shouldn't necessarily be placed in anybody's hands. It has to be placed with the appropriate 3 criteria. Does the person know how to use it? Have we shown them how to use it? Have they demonstrated proficiency in how to use it? Or the caregiver? Do they know what the numbers mean? And do they know how to take action on those numbers? So again, I definitely would put it in people's hands with that meeting those 3 criteria. So as a quick overview, how do I manage all people with diabetes? I want to make sure everybody has oral rehydration solutions or broth soups. I need to make sure everybody knows what the SADMANS meds are for them. And the glucose monitoring should happen with education, with appropriate purposeful glucose monitoring. And then more specifically, the people with type 1 diabetes, type 2 on basal bolus insulin, or anyone on SGLT2, same things, plus add a ketone meter with the same education. Okay, so we talked about SADMANS, and I did allude to it. I just think I think most people on the call probably know what the different categories are. The other thing is just to make sure people know where to find that, which would be on guidelines, the Diabetes Canada website, and it's Appendix 8, but you can find that on the website. Okay, so this tool is also available on the website under the Keeping People Safe bucket, and I will use this tool in my pharmacy, especially when people are at that stage of change and they want to know how to care for themselves. And I find that this one tends to help because it does, so Catherine, if you advance, it does show you, because some people don't know the different drugs which are in which classes. And so this helps me help them, especially because sometimes things are, you know, they'll change from Jardiance and then they'll combine the Jardiance with the metformin and then it'll become Synjardy. So, you know, we have to make sure that we're staying on top of all the different names that the person might be on and making sure that they know what's available or what they're taking. You'll see here's the list of the different fluids, but I still kind of try to emphasize what's the gold standard, which is those electrolyte replacement therapies, because that to me is the step that literally you're trying to rehydrate, and if you can't get that in, if you can't keep that down, that's when you unfortunately will need to that's a step before an IV, right? So and the difference between the the commercially available electrolyte replacement solutions versus possibly watered down apple juice, for example, is just the way the concentration of electrolyte to glucose is available in the product, and how in the commercially available products, they are physiologically balanced, and that's how it's absorbed across the brush border membrane. And then the last thing on this, well, sorry, other things on it of importance that I want to touch on is the fact that this tool couldn't be a be-all and end-all for everybody, but it did point out that if you're on insulin, you need to check your blood sugar more often, and you might need to adjust your dose. So the idea is just to give them an idea of that they should be aware of that they have to do it. And if they don't know how to adjust their insulin, we need to spend more time and explain that to them. Okay, this one is a little overview of, quite honestly, everything that we've talked about and we are going to talk about. But the one thing I wanted to point out is the fourth bullet, the last bullet, which says, develop a 6-day plan with your diabetes healthcare team. And what I thought I would share with you is one of the things I try to do in my practice is when somebody comes in, and if I actually have spent the time to work with this person and develop this 6-day plan, which would possibly include insulin adjustments, including possibly insulin adjustments with ketone measurements, I'll ask the patient who's on their diabetes healthcare team, and if they have an endocrinologist on board, or if they have in addition to the primary care provider, and if they are also seeing a diabetes educator, I'll ask them for permission that I may fax this over to their entire members of their team, so that we're all saying the same messaging. And I share that with you because if you guys are in diabetes education centers, I'm hoping you might do that similarly with us as community pharmacists. Ask the patient if it's okay that you share it with our team, with their entire team. As a community pharmacist, I would definitely, and I shouldn't say just community, family health teams, right? We would all scan it in, attach it to the file, there'd be a date on it, and if I was called and the person was sick and they couldn't reach anybody else, but they reached me, I would at least be able to help them just double check their calculations possibly. Okay, I think Catherine.
All right, so thank you, Susie, for that. So that was the preventive bit, as Susie mentioned. Now we're going to move on to really sick day management, where, okay, you have, maybe mild or early DKA. What do you do now? And so the disclosure now is that we are falling away from the guidelines, in that we don't have specific guidelines or guideline materials regarding treating mild DKA at home. And so really what's coming now is just practical tips as a healthcare professional that we are sharing with you for really sick day management. What to do if there's early mild DKA or HHS. And here we've defined that as blood glucose greater than 14, with an asterisk, which we'll talk about, and blood ketones more than 0.6. So the asterisk, many of you guys are probably already know, is for the incidence of euglycemic DKA with SGLT2 inhibitor use. And so you wouldn't necessarily need to have this criteria if you were worried about someone with DKA on an SGLT2 inhibitor. As Susie mentioned, does that mean that all my patients with an SGLT2 inhibitor know how to test for ketones? And as Susie mentioned, I worry more in people who are more insulinopenic. So where, again, that gap of where I worry that they have low insulin. So like the skinny type 2, or the type 2 who is on max dose, for example, or agents where I know that they have a low insulin endogenous reserve. In those situations, it's oftentimes when I'm prescribing it, of course, I'm counseling about DKA, and then their question will be, well, how do I know if that happens? I'll say, well, you can check with the ketone meter, and then the prescription will also include a ketone meter. And if they don't want to check for ketone meters, then I just tell them to go seek urgent care mention that they are on this medication and to check for ketones. Okay, so moving on, we're going to go through a few cases of different regimens for type 2 diabetes. So if you're not on insulin, usually we recommend to our patients checking blood glucose every 4 hours. Not necessarily checking ketones unless you're on SGLT2 inhibitors, and then insulin would not be applicable. If you're on SGLT2 inhibitor, if initially positive, I would continue checking ketones every 4 hours. If on basal insulin, then I would, again, check blood glucose every 4 hours. Check ketones every 4 hours if initially positive. And again, because they're on basal insulin, they won't have any rapid acting, and so I wouldn't suggest corrective insulin unless they happen to have a prescription or rapid acting insulin at home. Similarly, for mixed insulin, the same algorithm. If you're on basal bolus insulin, I would check every 2 hours, not because I think the disease is worse, but more because we can act on it. There's sort of no point in checking more frequently if you can't act upon it. And so with basal bolus insulin, I would check every 2 hours, both blood glucose and ketones. And then in terms of insulin, Susie's going to walk us through different algorithms for corrective insulin in a few minutes. But I think the most important column is coming up here, which is when to go to the emergency department. And we'll reiterate this again. If blood glucose continues to rise after 8 hours and ketones more than 1.5 hours. You'll note that a lot of sources and references will say 6 hours. I've indicated 8 here because it's hard to do every 6 hours when you're checking every 4 hours. So, and then the other thing is if ketones are more than 1.5. So I'm going to hand this over to Susie now.
Actually, Catherine, keep it on the other one.
Yeah.
So Catherine was telling her stories and how she was embarrassed because one of her patients actually ended up in which I love that she's so honest, because it just makes it like, oh, thank goodness that it happens to other people too, right? So I did also have another story where I had somebody who was on an SGLT2 and basal insulin, and they were started on a GLP-1. And of course, you can imagine at that time, they're starting a new agent, they get all this different state of change, and they're kind of thinking, okay, what else can I do? So we started also looking at the healthy behavior interventions, including reducing some, like they went to low carb. They did go keto, but they went low carb. So of course, later on, they start telling me they got stomach upset. So, you know, I'm a community pharmacist. I don't want to be having one of my patients in a merge. But, you know, they're on an SGLT2. They're on a low carb foods. I really, you know, unless you really spend the time to actually look at exactly, you know, but now they have stomach upset, but they're on the GLP-1. So you sort of say, but don't forget, I also, as they're going down on low carb foods, you're going to cut back your basal insulin. So are they with their stomach upset just the GLP-1, or could they possibly be maybe, you know, if you cut back the insulin too much, that's also sometimes what happens when you get that different risk. So it's an interesting story of trying to make sure that we're positioning ketone meters in the right people. And I think that's an example where I actually had my delivery guy rush a ketone meter over to them. They checked and they were able to manage at home. I've also had awesome experiences where my diabetes education center has phoned me and asked me how quick I can get a ketone meter ready for a patient family member to come pick up. And just to give you an example of how collaboration seems to work really well, and it was awesome just to be part of the team when they phoned me and said, I need to get a ketone meter to this person immediately. And you know that we are helping patients together and keeping them safe. Okay, so Catherine, actually go back one second. Catherine has gone over what to do in early or mild DKA or hyperosmolar hyperglycemic syndrome in people with type 2 diabetes. So I always like this, so the next slide is going to be on type 1, but I always like to say to myself, actually go back and think, what would be the difference? What would be the difference in the slides between a type 2 and a type 1? Because sometimes you're just like, oh, I got it, right? So let's look at the title, what to do in early mild DKA hyperosmolar syndrome. So you can imagine type 1, they don't have the endogenous insulin, so they're not going to have HHS, right? So they're going to go straight to DKA. And then if you look on the very bottom line, their type 1 would be on basal bolus insulin. Do you think we'll still check every 2 hours? Do you think we'll still check ketones every 2 hours? And so I like to sort of say to myself, where would I be different? And if we go to the next slide, you'll see it actually is all the same, except for the fact that there's no HHS. And the only difference is because the risk of DKA and progressing is so much faster, the go to emergency department is to blood glucose, if the blood glucoses continue to rise after 6 hours instead of the 8 hours. All right, next slide then. So when it comes to, yeah, if you go to the next slide, sorry, Catherine. Oh, good, thanks. So when you go, when you look at this one is the algorithm for people with type 1 or type 2 diabetes on basal bolus insulin. And I just wanted to point out a couple things. So if you forward slide, you can see that, of course, if we're if we're having a low, then of course you're going to treat the low. But that if you're vomiting, that's when it's not, because we're now sick, right? So it's not just treat the low, but if you're vomiting, contact your diabetes team, because we are worried that that is a symptom of DKA. Okay, next. They have a 4 to 16 as a blood sugar norm, but you can see if there's no ketones, then it's just take your usual dose. Unlike when you do have moderate ketones or blood ketones above 0.6, that's when we have that hyperglycemia kind of sick day, more counter-regulatory hormone, which is why we need to add the 10%. And I know so many people will have in their sick day, of course, they're vomiting, they're not eating as well, and they always were, why am I still taking my insulin? And I think that hopefully by explaining that, you have more confidence as to why it's important to not stop your insulin and to definitely even increase depending on the ketone level. Okay, I'm going to skip over the rest only because it's kind of there. And these are available through, you saw St. Mike's websites, and then the other one that Catherine has is the Alberta Health Services. My little point is that sometimes, see how this is done by weight, sometimes you'll still see people who are insulin sensitive. So I think take it with a grain of salt. You can see that as the weight goes up, you'll need more insulin because possibly you have more insulin resistance. But sometimes I'll really just do it based on ketones and blood sugars. Catherine, did you have anything else to add about those?
No, I mean, it's just an example of resources that are available across the country. So you don't need to reinvent the wheel, and oftentimes I've seen people share it on the Diabetes Canada platform. So I think the important part is individualizing it to your patient and making sure that you do the education.
Perfect.
So we're going to move on to really sick day management. And then I see there's some questions coming up, and so we'll finish up quickly to answer those questions. So for really sick day management, as you can probably guess from sort of the tone and flow of this presentation, our clients need to get themselves to the hospital. And what situations would be the absolute you have to go would be can't keep down fluids, change in level of consciousness, persistent hyperglycemia despite treatment for more than 6 hours, persistent hyperketonemia despite treatment for 6 hours, and lastly, to lead into Dr. Cheng's presentation, if you have hypoglycemia, because obviously the management that we went through will result in hypoglycemia, and if you can't balance that off, treating ketones with the glycemia, then they need to come into hospital. But again, it's very individualized. If you are not confident in someone's self-management, then you should have a lower threshold for sending them to hospital. So someone who is not savvy about how their medications work, who you're not certain will hold the correct medications, would just be go to Emerge. That's the safest thing for you right now. So I hope that you're now able to counsel clients effectively on sick day management, describe a stepwise approach for individualizing ambulatory management, and list 3 reasons for which adult clients must go to the hospital. Just to finish off with, and to lead into Dr. Cheng's session for next week, I did have 2 more stories from the front lines of 2 of my patients that ended up in hospital due to other reasons other than COVID-19. And so in this case, I'll start with the twist. The twist is home-baked bread resulted in it resulted in my patient going to the hospital. So as you know, baking is a comfort activity, and yeast and flour are now extinct in the grocery store aisles. And so one of my patients, type 1, on an insulin pump, very well managed. His wife was making home-baked bread. Early that week, he had some, had underestimated dose and was hyper. Later in the week, it was a different loaf, a different flour. And because he had underestimated previously, he then overestimated. He went for a walk and unfortunately did not have any of his supplies with him, was passed out, was found by a bystander who called 911 and brought him to the hospital. I think after he was given glucagon, his blood glucose was found to be 2.9. And so another thing to counsel our patients about is a preventable way of entering into hospital. And then my other case was another woman who had gone to Emerge, and I was emailed urgently from the Emerge R4 saying that your patient is having recurrent hypos, 1.4, 1.9, you have to see her urgently. And then further history from my nurse revealed that it was via the Freestyle Libre that she was getting 1.4s put to 1.9s, but feeling fine. And so she was one of those rare, maybe not so rare, patients where there's poor correlation between the Libre and capillary blood glucose. So I'm just going to finish off there. We're all in this together. We can do it, especially by staying home and staying safe. So I'm happy to answer any questions. I see that there's one question here already. Susie, do you want to take it? The question is, what role do DPP-4 inhibitors play in DKA?
Yes, quite honestly, they don't increase your risk. So they would be, if we go back to the slide, they would be the same as all people with diabetes. So unless that person on a DPP-4 is also on basal bolus insulin, for example, where we're really just thinking about the endogenous ability to make insulin. They would literally be just at the very top they're just all people with diabetes. So what would I do? I would make sure that they have a glucose meter if they know how to use it and have oral rehydration solutions. And of course, it's not part of SADMAN, so you wouldn't have to hold it.
Yep, so great, thanks, Susie.
I saw that someone raised their hand. We don't have a way of letting people's mic go live and ask a question. So if you do have a question, you just have to type it in the Q&A box.
Excellent. So I'll read out the next one. Blood ketone strips are expensive and expire. How realistic is it to give to all our type 1 patients with diabetes? Good question. So I think let's just make sure, so it's true that they are expensive and they do expire. Let's make sure that we are not just jumping to that conclusion. Let's double check that they have a drug plan, and if they have a drug plan, let's make sure that we still make it accessible to them. Other than that, although we do prefer blood ketone, there are urine ketones which also expire. The other option is, depending on how far they live from the pharmacy, you might be able to do it the way I did it, which, when they're sick, then you rush out and get it. Not the best. I wish there was a better answer.
Susie, there's another question looking at urine ketones. Are they good enough?
I think they're better than nothing, but they won't be as accurate or won't pick it up as early, but certainly better than nothing. So that's, I think, why we do, the guidelines even say we prefer blood, but there still is in all those charts moderate to trace markings for urine ketones.
There's another question here. I noticed ASA is not in the sick day sheet. Any reason why?
Because the sick day medication sheet was created to help prevent, quite honestly, acute kidney injury, which has to do more with the flow of the dynamics. So unless, oh, maybe Catherine, maybe they're referring to the fact that ASA is a form of an NSAID. So we should just stop it. So actually it is time, technically, it's just we didn't really sort of specify ASA.
I would say if you're using ASA at sort of NSAID inflammatory doses, then it should be held. But oftentimes it's used in, quote, primary prevention at 81 milligrams per day, which I would think has minimal effects on renal blood flow. But if it's easier to counsel your patient to stop an NSAID, then go ahead, because the few days, if you're not taking it, will likely be fine.
There's another question, is outpatient foot care still being provided? And actually, I think Wounds Canada just released a whole article about foot care, outpatient foot care in the time of COVID. So I'll make sure I get that and load it up on Timed Right.
Thanks, Susie. In my experience, I have, we do have additional resources out in the community of that foot care is still being provided. There's another question. Do we need to worry if blood ketones are above 0 but less than 0.6? Should we start extra hydration? I can take that. So blood ketones between 0 and 0.6. So if I was to check my ketones now, they would probably be 0.6 because I haven't eaten yet. But I'm not concerned because I'm not ill. If someone hasn't been eating, that's probably why their ketones are between 0 and 0.6. But if they're ill, that could be another reason. If they're ill, I would get them to start extra rehydration at that point. So it's more the illness rather than the ketone level that would trigger the extra hydration. Does that answer the question?
Yeah, although extra hydration, of course, is always, well, except for unless you're being told to restrict your fluids, but generally is always a good thing anyway.
Yeah. And then another question, have I seen marked hyperglycemia, acute insulin deficiency in COVID patients who do not previously have diabetes? It's hard to say. I haven't seen that, and the literature suggests that the literature has not been suggestive of that. What we do know recently in a cell metabolism paper is that marked rises in hyperglycemia portend, not surprisingly, a poor prognosis. Whether that's because of a direct effect on the pancreas has not been demonstrated, but more likely as a quote side effect / consequence of the severity of the illness.
Thanks, Stephanie. I'm thinking, could COVID in itself, sometimes you could be seeing undiagnosed or unrecognized diabetes. So maybe we're seeing things that are happening that it's not maybe COVID that brought it on, but it's the infection that caused the unmasking of the diabetes, possibly.
Potentially, for sure. So when I was attending on COVID, and not because I'm an endocrinologist, but actually everyone's blood glucose were very well controlled. Like it wasn't one of the things where, oh, I need to consult endo because the blood sugars are up and down. In fact, the blood sugars were pristine during COVID. And then in weird cases, I mean, like one guy came in on insulin, like 26 units of Lantus. And then, and this is not to say that there's like a protective effect because there's like a million other things going on in this guy's life. But then I discharged him on metformin and linagliptin only. So, so I haven't seen that there has been an impact on the glycemia in terms of hyperglycemia.
Yeah, so it's 1 o'clock. So I think we'll wrap up. I really want to thank Catherine and Susie for today's presentation. It was really great, it's really informative, and I think very useful resource. The recording will be available on Timed Right, should be available today or by tomorrow, and we'll get a recording up on diabetes.ca as well for future reference. So again, thanks Catherine and Susie, and thanks for everyone who joined in today.
Thanks, Grace.
Thanks, Grace. Stay safe, everyone.